So today we are going to have a lecture on pathological symptoms. Second. You guys can see my screen, right?
Yes.
Okay.
Yes.
Okay, I would appreciate an interactive sessions with you guys this afternoon. Okay, I think this is quite important topic for us in practical. All right, so our first lecture today is on the pathological visual symptoms. So I'm going to cover urgent ocular care on the following lectures. All right, so it is all about the recognitions and management of acute eye conditions. All right, so when you see this situation, when a patient is having a trauma or injury on the eye and they are coming to your practice, have you experienced this before, any one of you?
No.
No.
With the
No.
stick never lah, but got trauma yet.
Trauma, what kind of trauma?
The father is getting cut by the like strepsil
Okay.
strepsil ubat
Mhm.
the floor the anak
Okay.
accidentally like cut on it.
I see. So what kind of injury that you have seen?
There's a on the cornea we can see like the scar like the kopek like that. I can feel the like kertas the kopek like that. Yeah.
I see. You mean on the conjunctiva ke?
No,
Where is
cornea. Cornea.
sorry, on the cornea is like peeling.
Yes, peeling.
Is there
It's a feel line. Yeah.
Is there any other signs? Is there any other fluids or discharge?
Tearing, no fluid,
Mhm.
tearings and redness with pain.
Okay, I see. Is it on the central cornea or peripheral cornea?
There's a few scratch. I would say scratch is
A
a
scratch.
center and peripheral also.
I see. So how did you manage that patient? What did you do first when they first arrive?
I asked about the reason,
Mhm.
and I asked about the reason,
Mhm.
the causes, what is the causes, and pharmacy refer him to optical shop.
I see.
So he tried to get medication from pharmacy, eye drops, but pharmacy refer to my practice. So what I manage, I don't give any no, I just assess and give some
What
sleep
type?
lamp. I refer.
You
I do
refer.
sleep lamp
So
assessment. Then I refer.
did you check the VA of the patient?
Yes. VA slightly drop with glasses, maybe around 6/9, still manageable. So can be said not so affected lah, because that one is old glasses.
I see. Okay.
Yeah.
So vision, only vision that you check, and then slit lamp you mentioned just now, right?
Yeah.
What else? What else that maybe your practice don't have, but you should actually, you have gone through few semesters, right, of learning. So in your opinion, what kind of other tests that you should do for this kind of case? Other than VA and slit lamp? Hello?
Use the OCT.
OCT. Okay, why OCT?
Check the cornea, like until how deep the damage is.
Okay, all
Until which
right.
layer?
Until which layer is there any perforations on the cornea or not, right? Okay. Is there any others?
How about laceration test?
What test again? Sorry.
Laceration test.
Laceration test. Okay, can you please explain why?
Have we wait
Hmm?
how deep the cutting is it involved, or is it, am I correct?
Okay, so it's about how deep the layer
Yeah.
is injured or being injured, right?
Uh-uh.
Okay, do we need to check IOP for traumatic eye patients or not?
Yes.
Yes.
Okay, so IOP is also one of the triage that you should do in injury patients, okay, or any blunt or sharp injured patients on the eye. All right. Thank you very much for your sharing. So this is basically VA is the most important. Okay, once patient comes to you, sometimes we feel that the injury is severe, okay, or maybe there is hemorrhage, or maybe the eye are so swollen, then you are afraid of, whether patient can see or not, that kind of thing, right? But actually, VA is a must for all patients that are coming to us. So we have to try our best to check their visual acuity, okay? Because that will be our baseline lah. So this is just a funny photo for you guys as a future optometrist, okay? All right, so pathological visual symptoms refer to visual disturbances or changes that may indicate serious ocular, okay, first is serious ocular or systemic diseases, okay, or systemic diseases. So these symptoms require careful evaluations, okay, because they may address whether it's urgent, okay, or whether it is life-threatening conditions, okay. So it is very important for us to make sure to take a detailed history, okay. A detailed history is very important for you to ask on the onset, okay. What does it mean by onset?
Seen when
Anyone?
happened.
When was it happen, right? Can you elaborate further when you ask question? When was it happen? Then patients like, blah, blah, don't know how to answer. How are you going to help with some open-ended questions or leading question for them?
This happening seen when?
Hmm?
Is it gradually, progressively to get this blur,
Hmm?
or suddenly?
Okay, so you can ask whether it's happening within few days, or is it last week, or is it last month, or is it like last 3 months, example, okay? And durations, how about duration?
How long this happening?
Hmm?
Week, hour,
Hmm?
or month?
Yes, correct. And then is there any pain associated with symptoms? Some patient they will be clueless. Okay, what is pain? What is basically pain? Maybe they feel pain, but they don't know that it is actually a pain. So how can you help patients to basically tell them that whether it's a pain, whether it's just a discomfort, whether it's just a grittiness, whether it's just a foreign body sensations? Mm. Because pain can carry a lot of meanings for patients. So how are you going to state this? Anyone?
Is it a
Ask patient to wait lor.
needle feel pain?
Sorry?
Needle
Needle.
feel.
Okay, needle feel pain. Okay. Any others?
Maybe stingy feeling,
Sorry?
like stingy.
Stingy. Okay. Stinging, you mean? Stinging.
stinging.
Okay,
Oh, stinging.
stinging.
Okay.
Okay, stinging, yeah, okay, part of pain, but stinging, it doesn't consider as so pain. I think maybe mild pain will feel sting. Okay, is there any others?
Did the patient facing any photophobia issue?
Photophobia, okay. How
Yeah.
you relate this with pain? How do you relate photophobia with pain?
Normally, photophobia will cause tearing, right? I'm wondering if tearing might caused by pain or something happen
Okay, what do you think? Or
because
how
of
about others? Yeah. How about others? What do you think if you have tearing, do you feel pain? That's why you are tearing.
When you feel pain,
Mm.
do you feel pain on the surface, like
Mm.
in the eye? So you can
Mm.
feel the sensations.
Mm-hmm.
Where the pain whenever you move your eye,
Mm-hmm.
and the pain come from outside or inside, and then associate with any other things that you can feel. Just have to let the patient describe the pain, because you have to pick up from the question you ask. Yeah.
Okay, correct. Very good. So basically, you have to be very detailed when patients stated that they have pain, they can carry a lot of meanings, like I mentioned before. So you have to ask in detail what kind of pain, where is it, how do you feel? Okay, because usually even if it's just a discomfort, okay, they will say that it is a pain. Okay, all
Maybe
right.
need to ask the
Sorry.
severity, yeah.
Severity, yes, correct. Severity also you can ask, so you can scale like number 1 to number 10. So 10 will be the most pain, and 1 is like the less pain. Also can, all right? Or you can use mnemonics also to remember the red flags. These are the other tips, okay, to ask for a detailed history taking, whether it's sudden, whether it's unilateral, whether it's distorted, okay, diplopia, eye pain, neurologic signs, and vision loss. So these are the most important mnemonics for you to remember on urgent ocular care or pathological symptoms by patients who has basically acute eye disorder. Okay. All right. Another thing is, okay, for patient, especially old patient, right? Okay, they might not be able to differentiate blur vision. Okay, everything also they will say blur. Even is this diplopia, they will say blur. Distorted, they will say blur. Even if it's only one eye blur, they will say both eyes blur. Okay, so we have to be careful also and to investigate carefully when you have geriatric patients, like especially 65 and above. Okay. All right, so you need to also practice differentiating whether it is urgent versus non-urgent symptoms in clinical scenarios, okay? So which we will go through these slides. Right, the must not miss symptoms first is sudden painless vision loss. Okay, vision loss without any pain or any feeling, just the vision suddenly lost. Okay, second, painful vision loss. Third, vision loss with systemic symptoms. Okay, systemic symptoms are fever, headache, or any weakness. Weakness can be limb weakness, can be weakness on speech, means slurred speech, any kind of weakness with our 5 senses. Okay, and then if there is sudden or new onset of lotus and also flashes, right? And then visual aura with weakness or confusion. So this is a sign of possible stroke or transient ischemic attack. Okay, or stroke patients lah. I mean, patients might need to be evaluated urgently. Okay, you have to refer to patient to emergency or any stroke units in Klang Valley. Okay. So when are you going to refer urgently? Okay, any sudden or rapid vision lost. Okay, so you have to ask patient again, when is the onset? What is the duration to consider it's rapid or not? Secondly, symptoms of retinal detachments or flashes, floaters, any shadow or curtain light. Okay, it can be symptoms. It can be symptoms of retinal detachment. And then suspected of optic neuritis or temporal arthritis. So this one is if you have fundus, in your practice, you can, if you detected any inflammations around the optic disc, then of course you need to refer the patient urgently to A&E. And then acute glaucoma symptoms. Okay, any one of you have detected a glaucoma patients in your practice? Whether it's acute or chronic or hypertensive glaucoma, any glaucoma cases. Have you ever detected that in your practice?
Yes, yesterday.
Yes.
Yes, okay. So can you share? Can you share, Kevin?
Yesterday we detected once
Mhm.
64 years old
Mhm.
male.
Mhm.
VA is normal.
Mhm.
However, the optic disc, everything is okay, but just only thing the IOP
Mhm.
was quite high, the
Mhm.
29, 30. And then we
Mhm.
took a second IOP is 30, 35.
Mhm. Both eyes or one
So
eye?
both eye, both eye,
Both eyes, okay.
both eye. So
Mhm.
with the interval of about 15 minutes,
Mhm.
and AC is G1, grade 1.
Mhm. Okay.
So we
Mhm.
refer immediate lah to the ophthalmologist for the confirmations.
Okay. Do you have
Yeah.
your preferred glaucoma specialist that you will always refer once you detected or you suspected the
We
glaucoma patients?
we don't have the
Mm.
specific one basically,
So you just
but
write a general letter.
referral letter
Mm.
refer to the next door lah, because next door is your specialist. So
Mm.
yeah,
So it's always a next door specialist lah.
yes, easy lah, because we don't want the patient to drag. Yeah,
Correct. Okay.
because if you ask them to go back and think, they will think
Mm.
again, saying they're there. So just drag them to the specialist to
Mm.
confirm. Yeah.
Yeah, that's a very good move. Okay. Any others? Just detected. Just now I heard a lady. I'm not sure who is that. A
Yeah.
lady mentioned. Yeah.
But
So
just
what?
but the case already been shared before lah. But
Mm.
my case is very significant. Optic
Mhm.
disc is CD ratio is 0.8, and then
Mhm.
IOP is high, about
Mhm.
32 for right eye and 28 for
Mm.
left eye lah.
Mhm. Mhm.
And patient which VA cannot be correct until 6/12. So that one is the primary open angle glaucoma.
Primary open angle glaucoma. So you check the fundus with?
Yes, cupping ratio is 0.8 to 0.9.
You check with what instrument?
Fundus.
Fundus camera. Okay, and then very obvious, right? And then IOP
Yeah, very
also
obviously.
high. IOP also high and also reduced vision. How about confrontations?
That time I didn't check for confrontation. Sorry, confrontation. Yeah. I check it. It's the nasal inferior cannot
Constriction.
detect movement. Yeah.
Okay, constrictions on the nasal inferior, which eye?
Left eye.
Left eye nasal inferior. Okay. All right, good. Okay. So it's actually very good for you to be able to detect that at this point of, at this you because you're still learning and everything, right? Okay. All right. So last is visual symptoms with neurological deficits. Okay, what is your understanding when you read this? Visual symptoms with neurological deficits. Can you relate to any of your cases in the clinic? Visual symptoms with neurological deficits. What is that?
It's about the nerve. Is
Mhm.
that is
Optic
impair
nerve.
for vision impair?
Optic nerve, correct?
Yeah.
Mhm.
There's something
Related
press
to visual
the
pathway.
yeah.
Correct. Related to a visual pathway.
Yeah.
Very good. Okay. Now, I'm going to share you a video. Maybe if you have learned before, just for a refresh course for you to see, okay, what kind of the visual pathway and also the related the related constrictions or anopia according to the brain structure. Okay, hold on, where is it just now? Visual pathway, Rhesus medicine. Okay, let's see this. Very good video for you. You can listen to the voice, right?
Cannot.
Cannot.
It's very soft.
Very soft. You can listen lah, but very soft.
Seems like no sound.
Seems like no sound. Okay, let's try again.
Can you share the link, Miss?
Sorry?
Can you share the YouTube to our chat box?
Can. Wait ah. I share to Kevin. Sorry, I cannot find the chat box. I don't know why. So
Okay.
Kevin can help me, please. Thank you.
Yep. I forward to
Yeah.
everyone.
Yeah. So take your time. It's about, I think, 6 to 7 minutes of videos, and then we come back at 3:30. Okay.
Okay.
Okay, have you done watching?
Yes.
Okay.
Yes.
So what can you understand from the video? What can you understand from the video?
The different parts of the defect, the visual field defect, can tell us the on which part of the visual pathway is defected.
Okay, all right. So basically for urgent care, okay, we as optometrists usually concerns at the optic nerve up to the front, optic nerve to the cornea, okay? But we also need to learn and aware that there are actually visual impairment that can affect from the optic nerve up to the striacortex, okay, which can lead to visual inattention, can lead to anopia, whether it's homonymous anopia, whether it's quadrantanopia, whether it's macular sparring, okay? So basically, if it's chiasma, this is chiasma, right? Optic chiasma, right? Chiasma to cornea, okay? It will only affect one side of visual field, okay? Or it will basically, the effect is half compared to if patients is having injury or lesions from chiasma up to the cortex. This will be, will have an effect on both sides of the eye, okay? So if you see this, what is this? What is number 1? What is this? What is this batang? What we call this?
Optic tract.
Optic tract. Optic tract. Okay. Optic tract, optic chiasma, and then this is optic radiation. Wait. Is this optic tract? No, I'm blood confused.
Optic nerves.
Optic nerve, sorry. So this is optic nerve, this is optic tract, this is optic chiasma. So number 1 is when patient has lesions on the right optic nerve. Okay, so patient will have total blindness on that particular eye. Okay, or total loss of visual field. Okay, number 2, this is optic chiasma. So when there is a lesions or injury at this point, patient will have bitemporal hemianopia. Half of the visual field or half of the vision on both sides will be gone. Temporal side. Okay, so they can only, when they look at the front, basically on the temporal sides is inattentive. Okay, they will not aware if someone coming from the right temporal or left temporal. Okay. On the third is optic tract. Okay, optic tract will cause homonymous hemianopia. So one side temporal of the left eye and one nasal on the right eye will be gone. Okay, so
It
they
is
will,
cause a stroke.
this can be caused by any growth. Okay, any abnormal growth. Okay, stroke usually, yes. Any traumatic brain injury by accidents, by any brain trauma lah. Okay. Will usually for stroke, it will be caused by the TIA. Just now I mentioned the transient ischemic stroke. It can lead to mostly homonymous hemianopia. Okay. And also quadrantanopia lah on a severe case. Okay, because this optic radiation is located in the midbrain. Okay, so our brain is basically folded. So you can see this purplish shading here. Okay, purplish shading at the border here is our cortex. So our cortex is folded. If there is any injury at this area, usually it will be easily to recover. Okay, but if it occurs, any injury occurs in the midbrain, okay, it's very hard to recover. Okay. And then macular sparring. So macular sparring is happening at the occipital area. What is macular sparring? Have you heard of this, macular sparring?
Is it something like scotoma?
Correct. So basically, only the macula is functioning. The rest, the peripheral macula, are not. Okay, so when they see, they can only see at the central visions. Only central vision will be on attention. The rest, they will not be aware. So they have to move their eye lah. Okay, like a tunnel vision lah somehow, like a tunnel vision. Okay, and macular sparring usually will be happening on both sides, bilateral.
Yes, they have to do scanning therapy, like scan the eye like that.
Unfortunately for macular sparring, there is no therapy. There's no low vision aid to help. It's like a dead end of visual field loss lah for macular sparring.
So Miss Eric, the number one is you call optic nerve. Number 3, that one is called optic tract.
Correct.
Number 4 is called what there? Number 4.
This is optic radiation.
Optic radiation.
Correct. And the number 5 is occipital lobe. Okay.
Okay.
All right. Okay, on the retinal level, okay, usually macula, it will be damaged. If total macula damage lah, it will be happening in degeneration, AMD, okay, age-related macular degeneration, and diabetic retinopathy. Okay, in diabetic retinopathy, basically the macula, when we have high sugar level, okay, it can cause dehydrations on the retinal layer. So the retinal layer will become thinner, okay, and when it becomes thin, then it will degenerate lah of the macular functions. Okay.
Which part of the retina is the pigmentation level or what? Is a deeper layer? Which layer mostly affected?
For diabetic retinopathy?
Yeah.
For diabetic retinopathy, usually at RPE layer.
Okay. The macular degeneration, also RPE layer.
Also RPE layer. Usually it will be happening at the RPE layer. You have seen OCT, right?
Yeah.
So later I will show you the OCT. Okay, so to get a better understanding. Okay? Any question you would like to ask at this point?
So far, okay.
So far, okay. Am I making it too heavy for you? Is it okay? Is it all right? It's okay, right?
Because Dr. Fu
Yes,
taught us the
okay.
same, so it's quite okay lah.
So it's like it's actually similar, but not that similar, but similar, something like that. Sorry. Okay, sudden loss of vision. Sudden loss of vision. Okay, sudden loss of vision can be unilateral. So if it's unilateral, it may indicate retinal artery occlusion. Okay, retinal artery occlusions. This will be your differential diagnosis lah once patients comes to your practice. Okay, retinal artery occlusions, optic neuritis, or ischemic optic neuropathy. Okay, these 3. If it's bilateral, okay, you have to suspect of stroke. Okay, stroke, papilloedema, or toxicity. Okay, what kind of toxicity, on your understanding, what kind of toxicity that can cause vision loss?
Drugs.
Okay, drugs. What kind of drugs?
Chemotherapy.
Chemotherapy, okay. Is there any others?
Steroid.
Steroid is systemic. It's not toxic.
Okay.
There's one poison that will usually using by a farmer. Okay, once they are actually exposed to that poison, okay, they can have high level of toxicity in the blood. It can lead to sudden vision loss. I think this is quite common, especially if you are practicing in suburbs area. Let me find the drug's name. Can cause
acid, I think.
Sorry?
Acid,
Acid, is it? How to spell that?
ACID.
SCID. No, not that one. That can cause toxicity. Paraquat. Paraquat. Are you familiar to that? Paraquat. Paraquat is usually used by a farmer when they wanted to get rid of the rumput-rumput of the bushes. So they will use that as one of the strongest poison.
Can you spell?
Paraquat, Paraquat.
Oh.
Okay. So sudden vision loss is usually painless. Okay, if it's painless, it can suggest vascular or retinal causes. Okay, retinal related lah if it's painless. And if it's
just now you mentioned the paraquat. That one is used to the farmer used to kill the what insect one.
Is it killing or for
the rumput, is it?
Yeah.
除草剂
Racun for wheat.
Yeah, racun
for wheat and grass control.
Yes.
Okay.
I last time I use it.
You use it? Really?
Yeah.
How do you use it?
For what?
I use it to spray the rumput.
Oh, okay. So you don't feel anything? I mean,
I was a farmer before, ma.
Oh, okay.
During young time, I assisting my parents to take care of the farms.
Oh, I see. So there's no effect on you or your parents who are using that, is it?
Last time, no scared how to pronounce one. Now scared already lah. No.
Okay. So I think maybe because of the handling is one issue lah. Maybe or the dosage also, the exposure of the dosage also is another thing. And then if let's say the farmer is doing that in a closed area, example, they have a garage and the farmer is doing that inside the garage, closed, right? So there's no ventilation. So the toxicity can, it's high risk of having that toxicity lah. Okay. So, but that is the poison that usually causing toxicity among us in Malaysia lah, for farmers. Okay, so if the sudden vision loss is associated with pain, so you can suspect usually it's optic neuritis or angle closure glaucoma. So this is optic neuritis. Okay, what can you see on the fundus?
This margin
damage, like edema, inflammation.
Yeah, it's like swollen, right?
Yeah,
it's swollen. Like something is pressing the optic nerve from the back. Okay, so the margin is uneven. You cannot see the cup. And indistinct margin lah, basically. Okay, so I want to share with you. Okay, as we are now, I've spoken to Prof. Azrin yesterday. So optometrists now are going into a community optometrist. Okay, community optometrist, we have to work with KK and hospital in managing patients. So in that sense, we have to learn on how the expertise or the specialists manage their patients, right? So I wanted to show you how important for us to detect this kind of issue for urgent ocular care and refer to neuro, okay, and refer to neuro. So I'm going to share you a little bit of knowledge, okay, on the optic neuritis and the CT scan, okay. Because when you see from the fundus, okay, you see it from the front. Okay, from the CT scan, they are scanning from the bottom face. Okay, so in this image, you can see that. What can you see from here in terms of the optic nerve?
Sorry, you might
I think you haven't
I will
shared.
share.
Yeah, which
this.
sorry.
Yes.
Sorry. Okay. What can you see from here? Maybe some of you have a little bit of knowledge doing X-ray before or CT scan. What can you see? How can you compare? This is right. This is left. From the bottom of the face, this is right. This is left. Is there any different?
Where is the
The
right?
arrow one is thicker, no,
Arrow
bigger.
one.
Yes, bigger. There is an enlargement of the optic nerve. Okay, this is how it looks like for optic neuritis. There is an enlargement of the optic nerve.
The white arrow there.
Yes, correct. How about this
What
one?
is the ratio compared with the right and left? The left seems like about 2:1. The ratio.
Ratio?
The size. That means you need to compare. Only you know. First
Usually,
the ratio, or you measure in the millimeter or what?
To be honest, I am not. I don't know how they measure, but usually when we look at the CT scan, okay, they are going for optic neuritis case, yeah. Okay, we are going to see one optic nerve is larger than the other.
It means this one from this picture, look at it, it's like about 2:1 like that.
Again, I'm not so sure how they measure that. The ratio, I don't think it's similar as how we look at the cup and this. Okay, but usually they will compare which one, is there any enlargement of the optic nerve or not? Because different patient will have different width of optic nerve. This width is varies according to individual. So that's why I say I don't know whether is there any ratio, normal ratio or not.
I think certainly there is a guideline. It's guideline from the ophthalmology or what?
That one, maybe we can check further lah. Okay, but what I wanted to show here is for optic neuritis, when they do CT scan, one optic nerve will be larger than the other. So this show an enlargement lah. Okay.
So let's say 2 also enlarged. How do you know? Can it be bilateral, or the optic neuritis is only unilateral?
Usually optic neuritis is unilateral.
Only papilloma, only bilateral.
Papilledema, yes, it can be both. We will see one by one lah of the scan and see what's the difference. Okay.
Okay.
Okay, and then B. B is coronal image showing enlarged left optic nerve as well. So we can see enlarged optic nerve. This is optic nerve right. This is optic nerve left. Okay. So basically it's like a swollen optic nerve, right? And then for CJ, this one is just for our general knowledge, okay? Because sooner or later we are going to analyze from the CT scans and MRI. At least we get to see where we have to see, okay? C is axial on the axial angle, and D, okay? Again, this one lah, the enlargement, different angle of scans that they are this study is trying to show. Okay, and then this is compressive optic neuropathy. Compressive optic neuropathy. So you can see the growth. Okay, there's a mass. There's a mass at the nasal side of the orbit. This is a mass. Okay, this is the mass. So it compresses the optic nerve. Okay. And then in this case, okay, this is a cancer case lah. Again, abnormal growth, left optic sheath meningioma. So it looks like this. Okay, it looks like this. And this is the enlargement as well. Okay, this is bitemporal hemianopia detected by an optician. This study is from was from US, yeah. Okay, so this is bitemporal hemianopia detected. So refer to a CT scan. So there's basically a compressing optic chiasm. So this is more posterior to the brain side. Okay, this is the optic chiasm. Okay, on how they see whether it's compressing or not, that the CT scan experts or the specialists that can explain lah. Okay, but this is where the optic chiasm looks like a swollen optic chiasm. Okay, this case is neurofibromatosis. Okay, in child, okay, cancer type as well. So we can see there is an abnormal mass as well at the back near to the optic chiasm. This is optic chiasm. This is the optic nerve. Okay, so this is already metastasized now. So this is our midbrain. This is our midbrain. LGN everywhere is here. Our hypothalamus is all here. Okay, this is a what? What is this? Anyone know or not? What is this? The flowery like structure here.
Visual cortex.
Okay, this visual cortex is here. This is our medulla oblongata. Okay, medulla oblongata, and this is the brain stem.
How to type medulla oblongata? How to type?
Okay.
Yeah, type at on the chat box.
Yeah, can.
Thank you.
All right, sure. Okay. All right, this is the optic tracts. Okay, this is how optic tract enlargement of the optic tracts looks like. It's like a shadowy like. Okay. And this is the optic radiations. Sorry, this is optic radiations. No, this is optic tract also. Enlargement of the optic tract. So large lah. Coming so large compared to the previous patient. Okay, this is optic tract. And becomes so large. Okay. Until the optic tract is displaced. So basically because of the mass, optic tract displaced. Okay. And this is superior quadrant tanopia. So superior quadrant tanopia just now happening at where? Who remembers? Quadrant tanopia.
Radiation.
Optic radiation. Okay, so this is the optic radiations area. Right, so basically this there's a dilated veins at this area that compressing the LGN and lead to superior quadrant tanopia. Okay, so I'm going to send you this article and you can have a look. There's so many scans that you can learn from. Okay, so let's continue our lecture. Okay, so basically this is the optic neuritis. Okay, usually it's happening unilateral and it can cause pain. Okay, flashes and floaters usually benign, but it can signal posterior vitreous detachment. So if patient comes to you, especially if they experience a sudden experience of flashes or floaters, then you have to take note. Okay, and for a severe case of retinal detachment, it can be associated with a shadow or curtain in vision. And I think this one you're familiar lah. Okay, next is distorted vision, metamorphopsia. Okay, So for distorted vision, usually what kind of test or instrument we use to check for metamorphopsia?
Amsler grid.
Sorry?
Amsler grid.
Amsler grid, correct. Okay. So usually it's in AMD or central serous chorioretinopathy, CSC or CSR. You know what is CSC, right? Or CSR, central serous retinopathy?
Yes.
Right? It's a common conditions as well.
For
Okay.
patient who anxiety, yeah,
Yeah, with high level
high
of
stress level.
stress. So what happened to the macula?
Edema.
Yes, there's a fluid entering the RPE layer and causing elevations of the macula. So the VA will be affected and reduced. Okay. So for visual field loss, it can be gradual. So gradual could indicate glaucoma. And then it can be sudden hemianopia or quadrantanopia, the one that I mentioned lah. So this oftenly related to stroke or brain tumor. Right. Next is diplopia or double vision. Okay, it can be monocular. If monocular, it can cause by cataract or corneal irregularity. Okay, if binocular, it can be neurological causes. Okay, such as cranial nerve palsy or myasthenia gravis. Okay, you know what is myasthenia gravis?
One of the disease caused by the autoimmune system, I think.
Correct. And what happened to the face?
Paralysis of the eye muscle.
Correct. Very good.
Ptosis. Yeah.
Correct. Okay. And then painful eye with vision loss. Okay, you can think of acute angle closure glaucoma. Okay, acute angle closure glaucoma, uveitis or scleritis. Okay, and then if the eye movement is associated with pain, you can consider optic neuritis. Right, so photophobia usually seen in anterior uveitis, keratitis, or migraine. Okay, so migraine usually will be very common to have photophobia or light sensitivity. Okay, so photophobia, when you ask patient, you have to ask them whether the photophobia is happening during the day or at night. Okay, you need to differentiate that. Because some patients, they have sensitivity with the headlight of the car. Okay, so some patients, even with a mild amount of sunlight, they feel sensitive. So you need to be detailed in how you ask the history taking. Okay, secondly, photophobia with red eye. This is very dangerous lah. If patient has photophobia with red eye, it requires urgent assessment. Okay, because we are afraid of inflammation. Okay, for color vision changes, okay, red desaturation is an early sign of optic nerve dysfunctions. How do you do red desaturation, or how do you check red desaturation?
Compare the right eye and compare the left eye looking at the red color.
Red color what?
Pen, any red color will do lah.
Yes, correct. Very good. Okay, so blue, yellow defects. If patient has...
Excuse me.
Sorry?
What Steven answered just now?
Steven answered just now is any red pen, any cap of the red pen.
Red pen?
The cap of the red pen. Any cap with red color, then you compare right and left. Is that what you mean? Am I making it clear?
Yeah, sure. Clear.
Yeah.
All right.
For the lady just now, sorry, I didn't get to see who is speaking. Is that what you mean?
Okay.
Is it okay?
Yeah, I can hear.
Okay.
I can hear.
All
Yeah,
right. Or the best is actually using a red cap of any drops. Okay, eye drops. Okay, with to make it standardized lah. Usually the clinicians or the optometrists will use a cap of the eye drops. Okay, Midrasil, Saclogel you can use. Okay. So for color vision changes, blue-yellow defects, it can point to retinal disorders. Okay, so any retinal related, okay, it can change the blue-yellow color detection. Okay. So hallucinations, okay, hallucinations or form visual images, especially for a patient with TBI, traumatic brain injury, or stroke. They can experience delirium. Okay, delirium is when patient is having half conscious. They are half conscious, whether it's mild, can be mild to moderate to severe. Okay, so these hallucinations or form visual images mean they hallucinate an image. Okay, example, they see apple as an orange. Example, they see apple as an orange, or they see a chair as a desk. Okay, different hallucinations lah basically. So it can happen in Charles Bonnet syndrome, okay, in visually impaired patients, and also all the other neurological diseases related to the, sorry? Yes. Related.
It's okay. I think just accidentally.
Okay. Related to the higher order of the visual processings. Okay. So example, Parkinson's. Okay, Parkinson's can have hallucinations and also dementia. Have you experienced any geriatric patients with Parkinson's or dementia, even strokes in your practice? Means geriatrics, right? 65 and above. But strokes nowadays, it can happen to young patients as well. Can happen to as early as 36-year-old. Do you have any experience with this kind of patients with hallucinations or maybe delirium? Anyone? No. No one. Okay. All right. Okay. So for for transient visual obscuration, okay, transient visual obscuration. Okay, patient can have sudden brief loss of vision. Okay, suddenly patient will have will get blind lah, but it lasting like very fast, like maybe 2 to 3 seconds in a blink of eye, then the vision will recover. This can be associated with raised intracranial pressure. What is intracranial pressure? Anyone? Anyone?
Increased pressure in the skull, inside the skull.
Correct. Very good. So this can lead to papillary edema, bilateral. Okay. So
Means
there's
excuse me, miss. Is it means the vision will suddenly black out, then few seconds recover?
Yes, correct.
Oh.
But it's not in the case of papillary edema lah. Papillary edema will have usually it can lead to a permanent visual obscuration.
But how about if patient complain like just now you said it's a few seconds sudden vision loss, then recover after few seconds?
Okay, what is
the tentative
differential diagnosis you mean? It
Yeah,
can be amaurosis fugax. Mean it can be a sign of stroke or TBI lah, traumatic brain injury, that you have to be aware and straight away refer patients lah to specialists, especially if patient is 65 and above.
Okay.
Okay, if young patient, it might be caused by a low blood pressure. Okay, like they will get dizzy because of the dizziness, maybe not resting well, not eating well. It can lead to that transient visual loss. But for 65 and above, okay, it can be a sign of stroke or brain injury. Okay.
Someone in the chat box, fugas. What is fugas?
emeresis fugax is like loss of vision, transient loss of vision.
Oh, transient loss of vision. Okay, thank you.
Temporary vision loss can is related with CRVA.
CRVA, temporary.
Yeah.
Yeah, can. CRVA is an obstruction of the retina, so yes. Okay, so there are systemic associations that you have to keep in mind. First is hypertension and diabetes. So patient might have retinopathy, whether it's diabetic or hypertensive, macular edema. So again, especially if they have uncontrolled blood pressure or blood sugar. Okay. And then autoimmune disease. What kind of autoimmune disease that you aware or you have knowledge? Autoimmune diseases. Anyone?
Oh, SLE.
SLE. Yes, correct. Any others? SLE, rheumatoid arthritis.
Just now you mentioned the
Myasthenia
phase
gravis. Correct. Okay, myasthenia gravis. So this all autoimmune diseases can lead to uveitis and also optic neuritis. Okay, so giant cell arthritis, sudden vision loss in elderly. So this is an emergency. Okay, and then for stroke or transient ischemic attack, hemianopia is transient visual loss. Because the transient visual loss. Okay, so basically vision is the most precious sense. So loss of vision is a serious complaint that requires immediate attention. So if it's left untreated and permanent, it changes the patient's life significantly, especially if it's bilateral. And because I'm doing my patient's stroke, right? For stroke patients especially, most of the cases, it can actually be detected in the primary eye care. Okay, in the primary eye care. And the earlier detections of the attack is the better, because at least we can prescribe patients with any pharmacological intervention or any visual rehabilitation. The faster is the better, because our brain neurons, it has to be intervened as fast as it can. Okay, if you leave any conditions untreated, okay, especially related to vision, after 2 weeks, that visual problems can be permanent. Okay. So basically, what is urgent ocular care? Immediate attention to ocular conditions that may lead to visual loss or systemic complications. And it includes sudden vision loss, severe eye pain, trauma, or red eye with visual disturbances. Any question that you would like to ask? So far, can we rest for 5 minutes and then we continue?
No vision therapy can be done. Let's say got hemianopia lah.
Yes. They
lah.
are. There are
Got stroke.
there are therapies that can be done for that patient. It's just that we don't have expertise among optometrists to do that. And currently, occupational therapists are getting our role in that sense. So in the future, we need more neuro-optometrists to be involved in the TBI, traumatic brain injury.
It means occupational therapy. Are they doing sort of like massaging the type of job to release the symptom, or to help them to for recuperation or recover? Or
They are doing the visual therapy. Occupational therapists now, they are actually doing the visual therapy. They are doing scanning, as example for a stroke patient, right, who is having hemianopia, permanent one. So they need to learn how to see things. Okay, so they need to do that training lah, scanning training, to basically to deal with that visual field loss. Okay, that is management. In terms of therapy, there is also a scanning therapy. Means during the first and 2 weeks of attack, after the stroke attack, if they try to scan themselves, okay, they are like one task lah, that they have to see A, C, B, C, 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 D, C point A, B, C, D, and they have to do it regularly during that 2 weeks of time, and they might recover, they might get their vision back. So instead of having visual field loss, okay, the visual field loss can be how to say, can be retrieved back. Am I making it clear, Stephen?
Yeah.
Yeah.
Yeah, thank you.
Okay, so give me about 5 minutes, okay, and then we come back.
Okay, thank you.
Okay, all right.
I
刚才都讲到什么？不好意思，有 customer 咧 miss 嘅。
Did someone call me? Anyone?
No.
No one?
Just
Okay.
No, we are talking only.
Yeah.
Oh, okay, all right, all right.
Steven, Steven.
什么事啊？
Steven, do you have any idea about the community optometry short course, something like this?
Oh, there are recently optometrists has formed a college optometrists leading by Prof Aslin. Then they work with AMO to form these community services. So they are promoting the some sort of like specialists lah. They want to train the optician to do the sort of like auto care lah. Maybe they want to become a call contact lens specialist lah, or they want to call BV specialist lah. So they want to have task of specialist registration lah within the MOC. They work with MOC, you know. So in the future, you need to go to the training only you can qualify to perform like BV specialist, BV type of thing lor. And also they work with MOC that you need to go through the psychopathic short course in order you to qualify to use a drug to do the psychopathic, that type of thing lah. The idea is like that lah. Initially, I got objection because it's not well planned yet, but now it seems like they already convinced the eye specialist, then they agree, then and also they directly go to see the minister. The minister approve of this, so MOC also need to follow the minister. It's not approved at the MOC level, it's approved at the minister level. So the MOC just follow, cannot say anything lah. It just follow the direction they put the proper guideline. The guideline come out already, you can, they also already recently lah. In May, they already come up with the guideline.
My question is actually, we must go for some short course, right? Then only can use the drug, something like this, right?
Yeah. They want us, the one
any
the
chance
to
that
attend the
since we are still studying and still we have the momentum to study, can the short course to be commenced in our SAGI university first? Yeah, this is a good thing to think of lah. So we can continue the short course for 2 weeks, or I don't know how long is the short course.
That one we can, after we can talk to Professor Aslin, see how whether he can do the short course for us or not.
Yeah, continuous. Then after all, you need to go back to the study again.
Yeah. Can talk to Prof. Aslin. Maybe you also know Prof. Aslin. You can call him also. If can, then I call him and talk to Prof. Aslin and Encik Ahmad, the AMO president, see how to make things work.
Yeah.
请问
Of
那个
course
是
you
要
have
多少
to
天啊？Few days only, right? The
什
short
么
course 要几天报的？
tentatively 我们 plan 是1个礼拜这样的 short course 啦，
I
我要
to
整个
also
礼拜
try
的
to
啦。
deploy.
但是他还没有 come up proper 的啦，因
Also
为
have to
还没主办过嘛，第一次啊，
also
但
have to
是
talk
他收
to
费多少我也是不知道啦。
Steven, before you talk to Prof. Azrin, you have to talk to Dr. Fu first lah, you know? Yeah. Discuss with the faculty first.
We
Then
can
only
go
approach
together
the
lah. I think few of us interested one, maybe during class we can directly talk to Dr. Fu, see how lah.
Okay.
Okay
I think it's good that we can organize one shot for SETI faculty. So I'm sure there's a lot of us are keen to take part lah.
Based on the MOC, because it also involved MOC, I think last time that we talked in the MOC meeting that we open to all the whole optometry in Malaysia, all the optometry in Malaysia, not open for one university only. They invite the whole Malaysia optometrists. We talk to Prof. and see how.
Okay, let's start. Okay, can I start?
Yes.
Okay.
Yes.
Okay,
Yes.
so basically vision is the most precious sense. So loss of vision is a serious complaint that requires immediate attention. Okay. If it's untreated and permanent, it changes the patient's life significantly, especially if it's bilateral. Okay. Yes?
Sorry, Miss. No slides.
Yeah. Now it's good. Now it's So what is urgent ocular care? So urgent ocular care is a condition that may lead to vision loss or systemic complications. First, it can be vision loss by so many reasons. Another one is basically in Malaysia, it can be caused by diabetes or hypertension. Okay. And then it can be sudden vision loss, severe eye pain, trauma, or red eye with visual disturbances. So there are some key red flags in eye complaints, meaning to say that if patients is complaining this, then you have to be aware, highly alert. Okay, first is sudden vision loss, whether it's painless or painful. Okay, second, severe eye pain. Severe eye pain, like I mentioned, you can put it in a scale or photophobia. All right, and then red eye with visual loss. Okay, red eye with visual loss. Chemical injury or ocular trauma. This one is very obvious lah. Okay, if patient is having any accidents, okay, any accidents in the workplace related to chemicals, then you have to straight away refer to the emergency. All right, and then diplopia. Diplopia is also a serious concern, ptosis, especially if it's sudden or visual field lost. Okay, so when patients come to your practice with red eye, how red will you consider patient is having red eye? I think this is quite tricky for most of us, right? When patient comes and then patient say their eyes are red, but how red is considered red eye? Anyone can explain?
Yeah. To me, if the kind of red is not causing any swelling or hemorrhage, I mean the bleedings at all. So or any foreign body, it's not considered urgent.
Okay.
Can put in an observe to me.
Okay, so you will just observe first in that case lah. Okay, but how red then also doesn't matter whether it's very red, as long as it doesn't have any associated symptoms, you will just observe first. Is that what you mean?
Of course, I do need to have a history, what it causes that, or it's just sudden, or because of right upping. If it's not the dangerous act, I will put it as a observe first, because we will see whether it will recover.
Okay, so
For
red
me,
eye, yes.
For me, the red, how red, just now you say how red ma.
Yes,
So
how red
let's say
considered
from
red eye?
temporal conjunctiva, the white part, I can see more than half, I mean less than half of the white part that I can see. So I will say it's a quite red lah.
Okay, so basically, we have a scale, right, for the limbal injections.
Yes, yes.
So you have to see the scale. If the scale is around 3 to 4, is considered severe lah. So you basically your reference will be the limbal injections. Okay. Secondly, if there's any subconjunctival hemorrhage, you know what is subconjunctival hemorrhage, right? You know not subconjunctival hemorrhage.
Yes.
Right? Okay, caused by what? Subconjunctival hemorrhage.
Versus breakage.
Sorry?
It's a versus breakage.
Yeah. Okay. What will be the common systemic cause of subconjunctival? Yes, high blood pressure. So when you see patient with subconjunctival hemorrhage, it is a very helpful if you have blood pressure machines in your practice. Okay. All right. So it is good to have blood pressure machines and also blood sugar check. Okay, blood sugar check in our practice lah. Nowadays, it's quite important to have that because of the rising systemic disease. Okay. Okay, so these are the common urgent ocular condition. First is retinal detachment. Okay, and then CRAO. Okay, what is CRAO? What is CRAO? Central retinal arterial occlusion. Correct. So this CRAO can cause sudden painless vision loss. Okay. Thirdly, acute angle closure glaucoma. It can cause pain, halos, red eye. Okay, pain, halos, red eye. And then orbital cellulitis. Okay, it can cause proptosis, fever, painful movements. Okay, so orbital cellulitis can be caused by thyroid. Okay. chemical injury. So you need to have saline in your practice as well in case you have any chemical injury. So any patient coming to you with chemical injury, does not matter what kind of chemical, you have to irrigate until the ambulance arrive. Okay? Do not just refer patient to hospital straight away. You need to basically irrigate to reduce any meltness of the cornea or the conjunctiva. Okay? So if visual loss is spontaneous and without any apparent reason, you need to check for trauma, right? And the persistence of sudden severe vision loss in one or both eyes. Okay, persistence, sudden, severe vision loss. Okay, means if patient blink, if patient rest, or whatever things, the vision loss is still there. So it indicate retinal artery occlusion. So straight away refer patient. Okay, and in my opinion, okay, for us optometrists, it's good to have a good relationship with specialists, especially ophthalmologists, yes, of course, for sure. Secondly, neurologist or neurosurgeon. Okay, neurosurgeon is quite hard to, when we don't have a high number of neurosurgeons in the country, but we have neurologists. If you have any friends or any one that you know that you can basically network with them, is good, so that you can refer them straight away rather than patient go to optal, check, and then optal say, oh, actually need to see neuro. Okay, because that hassle is actually can be avoided at the primary eye care. If you think patient need to see neuro, straight away see neuro. If you think patient need to see optal, then optal. Okay, and we have neuro-ophthalmologists as well, but again, not many. Okay, neuro-ophthalmologists, we have Sunway, we have one, and the rest of them will be in government lah, PPUM, and also UKM. Okay, only 2 to 3 neuro-ophthalmologists in the country that you can Google and search who are they. So you can help to refer to them straight away. Okay. Okay, this is how it looks like for blocking retina. Okay, you can see a silver light. Okay, silver wiring light in the fundus. Okay, but this you have to look at it carefully lah, because you might miss. It looks like some kind of reflections. Okay, sometimes you can mistaken it as artifacts. Okay, especially if you're using fundus with low resolution. Okay, and for central retinal artery occlusions, another symptoms that you can see, the optic nerve is pale, and there's a cherry red spots of the macula. This is on the severe case lah, means the retinal artery occlusion is already severe or 100% blocked. Okay. Next, white retina is injured, ischemic from the blocked retinal artery. So you can see a whitish fundus. Okay, a whitish fundus, sorry, and the white plaque. Okay, but the white plaque also you can miss because it's very small. It's very small, but if it's blocked, then the fundus can be ischemic or deprived, oxygen deprivation. Okay, this we call as branch retinal artery occlusion. It can be acute, yeah. It can be a sudden visual loss, which caused by this BRAO. We have set CRAO, we have BRAO. Okay. So, eye examination as optometrist, first, visual acuity is a must. Next, pupil. Okay, most of the optometrists miss this test, pupil test. Okay, pupil test is a must for any visual loss patient. Okay, I think you know how to check pupil, right? You have learned on the how do you check pupil?
Use a torchlight to shine directly and indirect.
Torchlight, yeah. Torchlight, okay.
Not torchlight.
Not torchlight lah. Okay. Pen torch. Why you cannot use torchlight? Why you cannot use torchlight?
Too bright already.
Yes, you
It's a
can
white light,
bleach their photoreceptors, so it can be another issue lah. Okay?
Okay.
Try to have a good pen torch in your practice for pupil test. So you can check direct, indirect, and also Marcus gun lah, alternate. Okay, so make sure you do that for all patients to make a habit, right? I think from now on, all patients also you can check pupil. Okay, because sometimes this kind of neuro issue, right? It always be missed because of this incomplete eye examination. Okay, next is retina examinations lah. Okay, and the eye examination has to be done within 2 hours of the onset of symptoms. If you do within these 2 hours, it can allow a successful emergency treatment. Okay, so during these 2 hours, you can do ocular massage, and you can also check the pressure and see if there is any perfusion, any injection, bulbar injection, subconjunctival injection, and this ocular massage also can basically regulate the oxygens lah. Okay. After 90 minutes, okay, after 90 minutes of complete central occlusions of the retinal artery, okay, the retina can be permanently damaged. Okay, so you see how important the time with the management or the treatment. Okay, the as soon as possible lah, ASAP, yeah. Okay, so non-traumatic vitreous hemorrhage. Okay, non-traumatic vitreous hemorrhage, it can cause vitreous detachment. Okay, non-traumatic means it's a sudden hemorrhage lah. It can cause by any bleeding on the vitreous. Okay, if it's a small vitreous hemorrhage, especially if it's on the visual axis, it can clear rapidly by gravity. Okay, so usually patients might not notice or may not appreciate the potential danger of this hemorrhage because of this issue. Okay, if it's very small hemorrhage, you can, if you're confident enough, you can observe first lah, especially if it's on the visual axis. Okay. So for vitreous hemorrhage, usually if it's mild, okay, what we do in the hospital is that we try to ask patient to lie on the face. Lie on the face or lie back. Sorry, lie on the face if it's hemorrhage. Small hemorrhage, lie on the face. And usually the hemorrhage will be clear after about half an hour. Okay, that is normally Ophtha will do lah. Okay.
Excuse me, what you
Yes.
mean slide on the face? It mean face up or face down?
Face down.
Face
Means
down.
face to
Oh.
the bed, on the bed.
Okay, okay.
But they are using the bed with the whole head.
Like
Not
we go
pressing.
massage
Yeah,
or the
yeah.
facial.
Correct.
Yeah.
Yes, correct. Do not pressing the patient's face on the bed. Okay. Okay. All right. Through retinal examination, okay, we can to rule out retinal tear and to confirm vitreous detachment lah. Okay, this one can use fundus or 90D. And horseshoe-shaped retinal test to prevent retinal detachment. Okay, so horseshoe-shaped retinal test to prevent retinal detachment. If you see this horseshoe shape, okay, how does it look? How does it look like? It's like, we just Google
U-shape?
and see. It's
You shape the
like,
pedal.
I think so. Let's just be confirmed. Yeah. So if you see this kind of tear, straight away refer, don't wait. Like this. Like a pedal, correct. This one. Okay, the horseshoe tear. So if you see this kind of tear, no observation needed, refer. Okay. Right. Okay. Vein occlusions may produce macular edema. Okay, vein occlusions may produce macular edema, but it can be resolved in weeks or months. Okay, so basically, any occlusions on the vein that lead to edema, okay, you can observe first. I mean, for us, optometrists in Malaysia, I think we still have to refer lah, this kind of edema, okay, and let the ophthal observe for weeks or for months, okay. So central or branch occlusions of the retinal arterioles, okay, usually embolic and may produce only temporary symptoms when the embolus moves downstream. Okay, for central or branch occlusions, okay, of the retina, okay, if it's small, if just embolus size, very small, just like a 1 to 2 mm emboli, okay, this you can observe first because usually in time, the embolus will be gone. It will be resolved by itself, okay. If it's needed treatment, then you have to refer for vasodilations lah. Do you know what kind of treatment that can dilate the vein or the artery? The current ophthalmology, the ophthal treatment that can dilate the vein or the artery.
Don't know.
You don't know. Okay. If patient is having macular edema, what kind of treatment that ophthal will usually do?
VEGF.
VEGF, anti-VEGF. Okay, so anti-VEGF is one of vasodilation treatment. Okay. Okay, for transient visual symptoms usually related to macula. Okay, transient visual symptoms usually related to macular disorders. Okay, and if patient is having central serous choroidopathy, it will resolve by itself around 6 weeks to 6 months. Okay, and idiopathic stellate neuroretinopathy and acute multifocal punctate pigment epitheliopathy (AMPPE), this can be resolved in few weeks. Okay, so for transient visual symptoms, you check the macula. If you have OCT, you can check the layers and see if is there any retinopathy or any pigment of epitheliopathy. Okay, what is pathy? What is pathy actually? What does it mean by pathy? Anyone knows?
Disease?
No. If neuritis, itis is inflammation, right? So if pathy?
Disorder.
Mm.
It's a medical term.
Lesion.
It's
Usually,
a neuro, if related to neuro.
Yeah, correct. You can say disease or a suffering condition lah. A disease, yes, correct lah. A disease or a suffering conditions lah. Okay, so this basically, if this kind of issue, okay, it can be resolved in few weeks. Transient visual symptoms, macula related. Transient visual symptoms, macula related, resolve in few weeks. Okay, ARMD and angioid streaks. If patient is suddenly having visual symptoms for ARMD and angioid streaks, it can resolve in few weeks as well. Okay, so if patient comes to you, patient is having ARMD and patient complain of transient visual symptoms, transient visual loss, okay, or transient, usually transient visual loss lah. So you can basically, and if you see there's no advancement of the disease, you can observe first, okay, and see about 1 to 2 weeks and observe on the progress, okay. Okay, so vision can be improved even with underlying cause persist. Okay, and of course, ultimately, it will lead to permanent visual loss. But because for this condition, patient is already having it. Patient is already having CSC, neuroretinopathy, pigment epitheliopathy, ARMD, and angioid streak. Patient already have. But patient comes to you, complain transient visual symptoms. So you can observe first, but of course, you need to set an expectation to patient. The vision, of course, will get worse, will get permanent, but not as now. Not as now, as now it is still in transient mode. Okay. So macular edema caused by a solar burn. After like we are watching the eclipse, or maybe you are sunbathing or sun gazing. Okay. So it can cause transient visual loss as well. Okay, it can cause transient visual loss as well, but usually the recovery is also fast. Okay, so if patient comes to you, so you need, if you see that there's a burn somewhere on the face or on the body, so you can check with them whether they are having any sun gazing or sunbathing or any eclipse watching, and they have that transient visual loss. You can be assured to them the vision usually will be recovered. Okay. Okay, severe and especially sudden systemic disorders, particularly those causing hypertension. Severe, sudden systemic disorders, okay, which usually causing hypertension. Okay, example, it can be hypertension, it can be idiopathic, it can just happen. It can cause by eclampsia or severe metabolic imbalance, okay, related to the kidney. Okay, this condition can cause temporary visual loss, okay, macular edema, or secondary retinal detachment. So how to solve the temporary visual loss issue is you have to settle the primary concern first, which is the systemic disorders. If patient has hypertension, they need to take the tablet. If patient has kidney issues, so they have to take related medications, or if they need to go dialysis, then they need to go dialysis. Okay. Then if they have any retinal detachment, of course, causing by the primary issue, then you have to treat that first. Then only the macular edema will reduce. Okay, so for patient with dialysis, patient with kidney issue, it is very common for them to have macular edema. Okay, it is very common for them to have macular edema. Retinal detachment can happen, but in very rare occasion. Okay, in very rare occasion. So you have to take note if patient under dialysis, if patient is having non-treated hypertension, if patient is pregnant, with of course with later age,
PM.
usually it's like pre-eclampsia lah. So need to be in check as well. Okay. Okay, blunt trauma to the head is less likely to cause visual loss. Okay, if there's any trauma on the head, it's very unlikely for patient to have visual loss. Okay, direct trauma to the eye and orbit. Okay, compared to direct trauma to the eye and orbit. Okay. So for direct trauma to the eye and orbit will likely cause visual loss. Okay, will likely cause visual loss, but has been known to cause brain injury, especially to the occipital cortex. Okay, so this occipital cortex, contricup optic nerve, and retinal damage, it can also lead to visual loss, but for occipital cortex, it's more to visual inattention or visual impairment instead of visual loss. But visual loss can be considered as a general impairment lah for all these conditions. Okay, for blunt trauma is very less likely compared to the other conditions. Right. So when patient is having trauma, you have to ask, where is the trauma? Is on the head, it's on the frontal head, it's on the parietal sides, it's on the occipital side, occipital at the back. Okay, or it's direct on the orbit, it's on the bone of the orbit, is it directly on the eye, directly to the eye? So you have to be specific with that. Okay, so optic nerve contusion, it can cause visual loss causing by the high dose of systemic steroids. Okay, high dose of systemic steroids. Okay, blunt injury. Okay, blunt injury can cause visual loss. Okay, symptoms can be severe lid edema, optic nerve avulsion, include orbital fractures, ocular hemorrhages, cataracts, and retinal damage. Usually, it's a punch lah, a punch direct on the eye. Punch is considered blunt. Our punch is considered blunt injury. So this can be caused, can cause visual loss. So these are the symptoms. So in this case, in this kind of visual loss, pupillary examination, you have to check on the afferent pupil defect, direct, indirect, Marcus gun. For you to make sure there is nothing damage to the visual pathway. Is there any visual loss or not? Confrontations if you can't, IOP, okay? But the most important again is pupillary examination. Okay? And if you suspect there is a much serious damage to the orbits, to the posterior orbits, or maybe the brain, straight away refer patient for CT scan and MRI. Okay, the best is CT scan. Severe direct trauma. Okay, severe direct trauma. Okay, any kind of trauma that is direct on the eye, it can cause perforations lah, like the eye is bocor lah. Okay. Severe hypotony, okay, bleeding, past can develop, chemosis, and visual loss. Okay, severe direct trauma is, in most severe case, how to say, the most severe condition that can lead to the worst symptoms. Okay, so if you have a case of a silver of steel, a steel made up of silver, okay, that enters the eye. Okay, example, if the patient is a toolman or a mechanic hammering the object and it goes to the eye, it can cause ocular perforations. And why does it mention specifically silver? Why silver? Because silver is so fine that it can perforate easily into the eye. Okay. All right. I think we stop here. Next lecture, we are going to continue on the post-surgery. Is that right? Is that all right?
All right.
You
Will you
guys?
share the video to us? Upload.
Yeah, can.
Thank you.
I wanted to edit something. I think I will send you before the following lecture. Is that all right?
All right.
And
Okay. So see you on the next lecture. Thank you very much for your attention and attendance.
Miss,
Thank
can
you
you
very
share
much.
the slide, right? Can you share us the slide?
Yeah, I will
Okay.
share before the coming lecture because I wanted to edit something.
Okay.
Is that all right?
Okay.
Okay. So
Sure.
this will be for both lectures, yeah? For lecture 1 and lecture 2 from me. It will be from this one particular slide, okay? Okay. All right. Thank you very much. Have a
Thank
good
you.
day.
You too.
Bye.
Bye-bye.
Bye.
Bye-bye.
Bye.
Thanks,
Okay.
Miss Ellie. Bye-bye.
Okay. Thank you. Bye.
Bye-bye.